So, sir, as we know that the atrial fibrillation is one of the commonest arrhythmic disorder. It's almost in 1/3 patients of arrhythmic disorder. It is finally diagnosed as atrial fibrillation. So, in your as of now in your practice, how common you have found this atrial fibrillation disease in your OPD and practice?
See, you need not call it as one of the common arrhythmia. That is the commonest arrhythmia.
Yes.
And atrial fibrillation, the etiology varies with age. In younger age, we have more of valve-related problems. Right now, still the rheumatic heart disease, though the incidence is less in India, still it is significant. And in younger age, if you come across atrial fibrillation, 90% of the time they have valvular heart disease, say less than 40 years, 50 years. But beyond 60, 65 years, it's a non-valvular atrial fibrillation is what is more common. As you said, rightly said, nearly 1/3 have. So, we the cardiologists are not the ones to diagnose atrial fibrillation. Actually, the general physicians and the general practitioners should be picking up the atrial fibrillation. And though ECG and so many other things are mentioned, mere listening to the heart sounds for 30 seconds to 1 minute continuously is enough. Just merely listening to the pulse or heart sounds continuously can easily diagnose atrial fibrillation. And hence, whenever any doctor comes across any old person, I won't say patient, any old person for any reasons, we should make it a habit to keep a hand on the pulse, just listen to see whether it is an irregular heart rate. If it is irregular heart rate, and he should be alerted for the possibility of atrial fibrillation. So, it is not that uncommon, and on the other hand it is very common, and once you identify properly, you are going to prevent a major catastrophe.
Okay. Surely. So, it is also very well established that the stroke is one of the thromboembolic disorder which is very commonly associated with the atrial fibrillation. And for the primary prevention of stroke, based on a various risk category, guidelines also suggested antithrombotic treatment. And sometimes we also found that the patients are treated with oral antiplatelets for prevention of a stroke. So, sir, what is your take on this particular aspect, that whether we can use this oral antiplatelet like aspirin and sometimes clopidogrel for
things like that? No, the answer is no. It does not prevent. In atrial fibrillation, antiplatelets, they do not prevent stroke. They only give the side effect of bleeding to the patient. So, we should not be using antiplatelets for treating atrial fibrillation. It is only anticoagulation.
Okay. So, as per your suggestion, oral antiplatelet should be avoided for the primary prevention of stroke. So, the remaining part is in oral anticoagulants. So, these conventional oral anticoagulants are available since last almost 50 to 60 years in worldwide and even in India as well. So, have you been happy with this particular kind of the group of the drugs for the stroke prevention in atrial fibrillation?
See, we have been using warfarin conventionally and the other phytomenadione also, but I won't say I am very unhappy, but that does not suit everyone. Like if you treat and sincerely do the prothrombin time in your same lab, same hospital and follow them up, and you can see as high as 30 to 50% of the patients, it will be difficult to get the expected INR. With the same dose, so they may be under treated or the INR value will come very low. You slightly increase, the INR value will go very high. And second thing, that it necessitates the patient to come to our lab and get it checked. It is not like for example, if you are monitoring sugar levels, yes, you can say okay, get a sugar at your local lab, call me 1 week later, I will adjust over phone. Okay. Like that kind of thing, it is not possible here, because it is not a routinely done investigation and very few labs only have standardized. I think that is the bottleneck of treatment. It is not the drug, the bottleneck is to identify whether the drug is acting properly or not. Point number one. Point number two, because of the varying food habits which has lot of influence on the drug levels of the body. So, for these two reasons, but I can say 50%, nearly 50% who after some 2 or 3 months will have a stable level with a stable milligrams, they all have been doing well. But the other half, we always had this thing in the mind, can there be a better drug? Okay. So, in that way these novel oral anticoagulations have really helped us.
So, definitely one point what you have mentioned, that the AF, atrial fibrillation, is one of the age related disorder. So, now this is one very regularly what we have seen in the practice from the physicians and the cardiologists as well. When the age is getting more than 75 or it is older patients and patient is developing atrial fibrillation, then there is some hesitation has been found to use the oral anticoagulants and sometimes NOACs as well. So, what is your suggestion on this particular concern, that shall we go ahead with this kind of the drugs, or we should find some another way to treat the patients?
This inhibition is there in everyone, because everyone mind they think older the patient, higher is the chance of bleeding with any anticoagulation, which is not true. On the other hand, the older the patient, the benefit is more with anticoagulation. If you see the studies, whether it is a warfarin related study or with a newer oral anticoagulation, it is the aged patients who are more benefited with the drug than the younger patients. So, actually this will be totally the reverse. If a younger patient comes, one can take a chance and wait and watch and all, but if a older patient comes, there is there is nothing like taking a chance, you have to give.
Yes.
So, there is a definite indication one has to give oral anticoagulation even if somebody is 85 years. See, the thing is, you cannot argue he is already old, why should I treat and all, that is secondary. Yes. But as I said, older the patient, higher is the benefit from anticoagulation if it is atrial fibrillation.
Sure, definitely. Age, definitely it's a major concern, but you should not worry for this age as a bar that you should for the hesitation of a treatment in this stroke.
And second thing is, higher the age is not equivalent to higher incidence of bleeding, which is not true.
Not true. Definitely. So, sir, we have seen there is a step-by-step changes for the treatment from oral anticoagulants to the newer kind of the oral anticoagulants. So, how will you welcome this kind of the concept of the newer oral anticoagulants? As you said that the monitoring of INR and PT is one of the major practical challenge when patient is on the VKs and warfarin and acinocumarol. So, do you find that this kind of the practical challenges and the problems can be resolved with this kind of the newer kind of generation?
Yeah, that's what it's a welcome change. It's a welcome new drug. If you see the armamentarium of cardiac drugs, very few places we were expecting some new drug to come. So, in that way, as I told, if this drug is very effective in more than 80% of patients, which I said with the oral conventional warfarin it was around 50%. So, it's a real welcome change. So, this drug was really needed. So, it has come and we have to really use it for the benefit of the patients.
Surely. So, definitely you must be using in your patients. So, can I know that in your regular practice, what percentage of the A patients are benefited with this newer concept of oral anticoagulation?
If you ask me that question, I think if I take only the atrial fibrillation, non-valvular atrial fibrillation, it should be about 30%.
Okay. And even in that, can we differentiate? There are 3 NOACs are available: rivaroxaban, dabigatran, and apixaban. So, what will be your preferable choice, or you might be change your idea, change your treatment pattern based on a different condition of a patient?
Actually, practically speaking, the difference is small. In some studies, in some way there is a slight difference, but whether that can be really translated in the real world and whether really it is applicable to a given patient, we do not know, because there has been no head-to-head comparison between the oral anticoagulation. See, based on in this study, this group of patients did better. In that study, that small group was better. So, based on that, we cannot say this is better in this aspect as compared to that drug. So, right now our take has been that most of the oral anticoagulation right now, unless we have used it for another 2 to 3 years, we will not be able to form our own ideas.
Okay.
Right now, whatever the idea we get is from the studies, and according to the studies, right now there is nothing, no strong reason to differentiate between the 3.
Sure, it's very well said by from your side, sir. Now, what that's you must have said that this NOACs can be used in AF kind of the patient, but still you have said that not all the patients are on this particular NOAC. So, can we have that kind of the reason that why all the patients are not on this particular kind of the newer concept of a drug?
Yeah. Why not all of them are using this drug? You can tell me the answer. You know the answer. What is the reason?
As of now, what we have discussed with the other practitioners and the medical fraternity, most probable reason is the cost.
Exactly.
Definitely.
Exactly. Most probably that's the only reason. It's not the non-availability; it is a cost. Now, whenever I start a treatment, suppose I am going to start a very costly antibiotic, which is there for 1 week or 10 days or 15 days, I am not going to really check the cost. If it is very effective, I am going to ask the patient to buy that, because it only a 10 days therapy or 15 days therapy, he also won't mind. But if I am going to prescribe him a drug which he has to continue for lifelong therapy, he has to commit himself that he is going to take it continuously. It is not like you take for 3 months, then subsequently you change to some other, it doesn't work. Yes. So, now right now the problem is that, of course, first I will see whether there is an indication. Second thing, I have to discuss with the patient whether he is willing to purchase it and use it indefinitely. The advantages, I will tell him that he need not visit our hospital, he need not get that medicine checked, and then get the investigation being done, and then there is a overall differences that is better than the older drug. All advantages I do say, but if he is not committed to spend that much money every month, then there is no point in starting. I will never experiment, like you just try 3 months and then tell me your answer. No, how can he tell his answer, or how can he tell his experience? No, is it not? It's not. So the main level of filter is at this level.
Okay.
So after explaining him the availability of newer drugs, I will ask his commitment. If he says, yes doctor, I will definitely try to continue as much as possible, then I will start.
Okay.
So whomever I have started, all of them have been continuing till now.
Sure.
In one of the husband wife, both of them are taking.
Okay.
Okay, so the thing is, right now the main problem is the cost. If the cost comes down, definitely it can be expanded to more wider range of patients.
Surely. So definitely it's very well said that cost is a factor, and even in spite of that, proper counseling and proper proper counseling to the patients regarding commitment of a treatment, that whether he will continue for a longer time, then and then we should go such kind of a treatment. Otherwise, as you said, patient will not be benefited and unnecessarily might end up with some kind of the adverse events like that. So sir, there is one more question, is that as a cardiologist, definitely primary prevention of stroke is very important, and if we talk about the other medical fraternity group as a neurologist, when the patient is developing a stroke and retrospectively he will is diagnosed with AF.
Yeah.
So this kind of the treatment will be applicable at both the side, for the primary as well as the recurrent prevention of a stroke. So this molecule will go in which hand, whether it's a cardiologist or in a neurologist?
See, the thing is, to decide on starting the treatment could be a cardiologist or neurologist, but subsequently the patient need not be followed only with these two people.
Okay.
So if the general practitioners and others also have been told about these patients, they themselves can follow up. Follow up means what? Ensuring the compliance.
Yes.
See, if you simply say, okay, continue to take this drug, come after 1 year, the compliance is going to go down.
Yes.
He may take for 1 or 2 months, then he will start leaving a gap of 2 to 3 days, then the gap will gradually increase. So the one reason why doctors ask the patients to come back at regular basis is that many times I won't change the single prescription, I will be giving the same prescription again.
Yes.
But the only thing is, I would have spoken to him, I would have asked about the disease, and I would have ensured that he has been taking the drugs, and he will also continue to take. So that kind of thing, a general practitioner or general physicians level itself can be done.
Okay.
See, they should be told about the disease, they should not hesitate to continue to prescribe the drug and ensure the. So the decision to start could be with cardiologist and neurologist, but the decision to continue or the regular follow up need not be always with these two people, because it may be busy or it may be more costlier compared to following up with the local physicians. So that should be our take up actually on this issue.
So this is a really good point, a good thought of point, that these drugs should be go beyond the cardiologist and neurologist level. It should be at GP's level, but they also has to ensure that regarding the compliance level and some safety aspect of that, so how they can tackle on this particular kind of the treatment. So thanks a lot sir for your final take on that. Major take on point from Dr. Kannan is that AF is definitely a major concern of a society. Previously, there are the older anticoagulants are going to use, but they have some practical issues like INR monitoring and also the longer compliance. And in place of that, the newer oral agents are also available. They are better, they must be effective and safe, but again, the cost is a major hurdle that each and every patient is not going to be benefited with this particular kind of a treatment. And the one important thought is also raised that we should go beyond the cardiologist and neurologist levels, so to spread the educational awareness and the scientific awareness of this particular drugs to at the GP levels as well. So thanks a lot, Dr. Kannan sir, and for providing your time and valuable comments on this particular treatment.
Thank you.
Thanks.
Thank you.
Sure.